Welcome. I'm Arif Nathoo, CEO and co-founder of Komodo Health, and I'm thrilled to be here today holding a special episode of For the Health of It. With us today, I'm thrilled to welcome Khadijah Ameen and Matthew McCurdy, two of the co-founders of Black Health. Black Health is a nonprofit advocacy group that partners with health professionals, organizations, and Black communities to better understand healthcare inequities and brainstorm solutions together with the communities who are impacted most. And I'd be remiss if I didn't mention that we are having this conversation in March, which is both Colorectal Cancer Awareness Month and National Kidney Month. Recently, Komodo partnered with Black Health to publish new research around disparities in the patient experiences of these two disease areas. So Khadijah and Matthew, thank you for joining us today. Welcome.
Yeah, thanks for having me.
Well, we all know that you met at Emory University's Rollins School of Public Health, but can you tell us a little bit about your origin story, your path to starting Black Health, your mission? Just give us a little bit about you guys.
Yeah, so we did meet in our graduate public health program. And in that program, we were learning about public health, population health, and learning more about health disparities. And something that we realized pretty quickly was that Black people were experiencing health disparities across different disease states, and we were dying sooner and just having worse overall health outcomes. But we really wanted to dig into more why that was and what could be done about it. So when we graduated, we created Black Health to really look at those structural drivers of health inequities and what how those could be addressed. So Black Health is a Black-owned, community-based organization dedicated to improving the health and well-being of Black communities. And we really do this through two focus areas, so education and action. So educating community members and health professionals about the impact of structural racism on Black health inequities, and then equipping folks to do something about it. So over the past few years, we've been creating engaging content, conducting workshops and trainings, supporting research, and hosting community events to create spaces for education and action that can address racial health inequities.
Oh, that's fantastic. Matthew, tell me about your story.
Yeah, I think Khadijah really covered the bases. You know, we were at Emory University really not satisfied with the way we were being taught about race, racism, and health. And knew that that was probably reflective of the larger way the United States really thought about racism and health. And I think it seems like a long time ago now, but you know, sort of that narrative has changed a little bit. We do feel like people do have a bit more understanding of the implications of racism on health, but the disparities haven't changed. They've actually worsened since those times. And so I think you know, we're really determined to understand how racism operates, and then to really intervene on those points. But yeah, we were four friends who saw an issue and decided to do something about it. You know, leveraging the education that we were fortunate to receive, but also you know the community ties and the community relationships that we have to build something that's been really cool.
It's incredible, and Khadijah, like just hearing the story. I mean, it's such an amazing thing to kind of, you know, see a problem that you feel really passionately about, to like put your minds together and to build an organization that reflects your values and your beliefs. And, you know, we know this a lot about Komodo. Is like, it was myself, my co-founder, coming together with something we really believed in to kind of create and to build. And it's just incredible to hear your story getting together, you know, from a public health point of view, coming from like, you know, seeing those disparities in action and asking yourselves, hey, we can do something about this. And how do we create both the awareness and then the infrastructure to actually deliver better care? So kudos to you for taking that leap and to do something in the unknown. You know, I want to talk a little bit about, the complexity of racism in healthcare and how it gets manifested in the day-to-day experience of Black patients. We know this, we see this. For those of us who have been in clinical practice or those who have just observed the healthcare system, we know that, that structural racism exists in all parts and so many parts of the healthcare system. I would love to just dive in a little bit with you guys on hey, there's a lot of work that's published on racism. Why aren't, we really, getting to the place that we want to? Like, what's holding us back? And I mean, you've seen so much, you've been thinking about this so deeply, but would just love to hear from your perspective why we aren't making the progress as fast as we want. And just like you said, Matthew, it's actually getting worse.
Yeah. I mean, it's funny as you were asking that question, like the answer is racism. It's a insidious structure that benefits certain groups and, disadvantages other groups. And sometimes unknowingly, but oftentimes knowingly, people continue to enact this system because it does derive benefits for themselves. We really believe that race is a social construct. And that's not to say that it's made up. That's just to say that it's an agreement that we've all sort of invested in. And now it has real social ramifications. It's not biology that makes Black people get sicker or have worse health outcomes. It's not genetics. It's the way that we've arranged ourselves as a society. It's the history that has an impact on who has access to resources and who doesn't. And so that system isn't going to be broken easily. And there's actually a very invested culture in making sure that it's upheld. And so, we really want to, continue to have that conversation because if we don't attack at the structure, if we just try to pathologize this and just say, hey, you can fix this by, enacting this behavior, or if people just ate healthier, or if we exercise more, we would be healthier. Those things aren't really going to work on a community level, on a national level. And so it's really about how can we create environments and restructure our society in a way that everyone has access to the things that are going to make us healthy. Everyone has access to the things that are going to allow us to have control over our health outcomes. I think, we hear this language as, we don't want to be victims. And I'm not at all saying that, Black people don't have their own agency. And, we're evidence of that. We created an organization that then, goes out and tries to help people. But there are large structures in place that are difficult to break down. And so, we use both research and action to sort of inform each other. And so like the report that we published with you all, is really a tool for us to go out and say, hey, these experiences that you have at an individual level aren't just your experiences, right? Here is the trend. Like, here is all the data that you can see that is evidence that this isn't just a individual issue. And then we can take that and say, this is a motivation for action. This is how we should proceed. So yeah, I think, the conversations are difficult. They're not always easy. But I think, it's a conversation we have to continue to have. Progress is slow, but it is still progress.
Yeah, I mean, it's such a truism that it's racism at the core that drives this, perpetuation of all the structures that continue to create that disadvantage. And I think coming from your point of view, and I really like the pairing of both research and then the infrastructure to go do something about it. I mean, getting those two things and pairing that up in your organization is really important, right? There are organizations out there who just do the research, who highlight those disparities, but then there are others who then take that and engage the community. And you found that so many ways the best combination of the two is to really go in and act, and use the data to kind of drive the kind of change you want to see. And I think that's a very beautiful thing. One, puts you in that position to, not only think deeply about the impact, but then to actually go do something. And then two, it actually is very motivating because you're very deeply in touch. Your backgrounds as public health epidemiologists, researchers allow you to have a very keen view to, hey, this is not just your experience. This is something we see across the country. How do we validate that? Help you just put some words to that, just so that we can start showing people this is real. I do want to talk a little bit about some of the research we've done with you and this belief that There's a lot more in it, and I'll cite an article from the Kaiser Family Foundation. They said that 25% of Black adults reported not having a personal healthcare provider, and 15% of Black adults reported not seeing a doctor in the last 12 months because of cost. We think a little bit about the impact of poverty, of the cost of the healthcare system, the way that it impacts Black communities. I'm really curious from your kind of perspective, and this is one of the challenges is as we start thinking about the impact of racism on the healthcare system, how do we better kind of educate and engage providers on their responsibility and their roles to the Black patient population? I would just love to hear a little bit about that, because like you said, we don't want to make it about, like the population as victims. We want to make it about the responsibility of providers to care the community. How do we have that conversation? Would just love your guys' thoughts on that.
So there are definitely different strategies that providers can take to really both build knowledge around the impact of racism on Black health and take action around it. So I think one initial step is just recognizing that Black patients have differential experiences and experience greater barriers to care, and having that initial recognition in order to then really build more equitable strategies to breaking down those barriers. Something else that is really important, and we're we really want individual providers to continue to grow their competency around anti-racism and understanding how intersecting forms of oppression impact health. But we're also very focused on structural competency. So not just individual health providers, but institutions at a higher level, building that competency to really critically recognize both the impact of racism, but even their institution's own role in perpetuating racism, and then really building systems level strategies and solutions to addressing the impact of racism. And lastly, something that we're always advocating for is more Black providers, more minoritized providers in the healthcare space, just as a way of just creating a more safe, culturally relevant, confident environment. And so for the colorectal cancer inequities and colorectal cancer related providers, there's definitely been movement in this space. We want to shout out the Association of Black Gastroenterologists and Hepatologists, that just a coalition of Black providers that have really been working aggressively around reducing colorectal cancer disparities.
Yeah, and I just to add to that, you made the point earlier, Arif, about language and just how important it is to be able to speak to, as personally as an individual or a patient, your experiences in a greater experience. But I think there's a learning and that providers have to do as well around language and how to speak to their patients about their experience and how to articulate, hey, what you're going through isn't your fault, right? You're actually within a system, within a community where it's difficult to be healthy, right? I see people all the time coming from this particular community that have these same issues, and really transforming medicine from an individual to a community-based lens is going to be really important. But I think, people go to med school for a variety of reasons. But I think ultimately, to make people healthier and to make people have, to, put well-being at the front. But I think we have to really challenge that system because it has been a system deep seeped in racism that's really led to a lot of the outcomes that we see today. And as Khadijah said, it's going to take structural change to then transform that system to be something different. But I think, first and foremost, it's about providing providers with that language so that they can speak to their patients. And then the solutions that you then recommend are different, right? We're not going to always have behavioral solutions. There are community interventions that can have a greater impact than somebody taking a medication or changing a behavior.
This is a great point. And, providers, I think about when I trained in medicine, so much of what we focus on is the individual and that impact on the individual, but we don't talk about community enough. We don't really talk about, we call them social determinants these days, but like we don't talk about impact of the community on in your life and like everything around you, on your habits, on your kind of social milieu, your environment, and how that plays into your health. And we just see such a like lack of understanding and awareness, especially around folks who classically train not to really dive into a lot of that, or just to make assumptions rather than asking questions. And so much of that behavior, to your point, is steeped in racism, and it's ingrained in how we train. It's ingrained in like how we practice, and all of those things are behaviors that have to either be unlearned or they have to be taught. And so much of that teaching is just not happening, right? Once you're out of med school, then it's like all the things that you see and you do in residency and beyond are just a byproduct of that environment. And you stop learning about, community that way, because you're just not, you're not seeing it, you're not talking about it, you're not being trained against it. So I think there's a lot we can do, right? I mean, there's so much we can do in the CME space just to continue to teach doctors about how to think about community, how to ask the right questions, how to have the right discussions, how to have the hard discussions. But, I agree with you, Matthew. It's not at the forefront of education. And it's like, to your point, something that has to change if we want to see that kind of change, play out with our providers. We did some work with you on looking at the racial disparities in CRC and kidney disease. And I want to talk a little bit about that because, there's a whole set of implications coming out of this that I think we can jam on, because I think it helps us put us in the right mindset for like what kind of change we can drive. And, in our research brief, we said that, among patients who underwent chemotherapy or surgery, Black patients waited an average of 8 days longer for treatment than white patients and were diagnosed at a later stage of disease. I mean, that's fact. And that is amazing that, the data will tell us that, but it's nothing surprising to any of you, right? I mean, this is like, to your point, this is the byproduct of racism in our system. So how do we, think a little bit about that? And I'm kind of curious your perspective on this, because I mean, racism is at the heart of this. But if we think about like, how do we start to engineer some of this change? Well, CRC is really well established, incredibly, in terms of like treatment protocols, regimes. We have the right kinds of screening. How do we kind of overcome the racism to do something about this? Like, what are the things that you guys would be advocating for? Have you seen this, thought about this? What can we do to make this better?
Yeah, so what we've done specifically related to CRC is we have a program that is distributing screening tests, right? So we know that if caught and detected early enough, that colorectal cancer is largely treatable and preventable. And so, we're working through the Good Down There campaign with a partner, Cottonelle, to really inform people on the importance of getting screened, the importance of having your family member screened, and then if you're having symptoms, to get into care to get a colonoscopy. So it's both awareness building, but it's also then breaking down that barrier of that resource, right? If I know that I need to get screened, but I don't have the funding, I don't know where to go get a screening test, I'm likely not going to get screened. I'm not going to interrupt, my daily hustle to make ends meet in order to take care of something that, largely, may have no symptoms or may not really be impacting my day-to-day life. So we're really trying to, step into and intervene specifically to provide that resource to people to get them screened. I'd also say, secondly, once someone does identify that they are positive potentially positive for colorectal cancer, it's about providing that care pathway so they can get the resources that they need. That's a part of our program that we're looking to build out in the coming years, right? How do we get people access to care so that they don't go into uncontrollable debt trying to be well and trying to be healthy? And so that affordability piece is really important as well. So I'd say, on that end, access and affordability is really what we're focused on related to colorectal cancer right now.
That's awesome. And I think it's such it's an opportunity for us to actually have these conversations and to start thinking about, what the impact is, because we don't just, reduce those 8 days by saying, okay, now pay attention to Black patients. We have to think about, all the reasons why it's difficult for someone to get screened, to get treated, and affordability comes into it, just the ability to get, from A to B, just to know what your options are, know your providers, education. So like all of these things come together. It's like, how do we take a multifaceted approach to doing this right? And I kind of applaud the breadth of your vision in terms of thinking about not just, okay, we can engage providers in this way, but like, how do we start really making affordability? How do we start rethinking protocols? Like, how do we really push a lot of these different dimensions that are going to actually drive a behavior change? I love it. I mean, I think you need that multifaceted thinking in order to make a change. And so really awesome to hear that.
I also think it's really important that we shift how we think about healthcare, right? The way that we've implemented our program is that you don't have to go to a hospital in order to get the screening test. You can go to the community organization that's in your neighborhood, who's been throwing events in your neighborhood since you were a child, that you're familiar with, that you may even know. And you don't need to go to, provider Joe Smith or John Smith, who, you've never met, right? And so really rethinking how, we structure healthcare and community care is super important, right? We want to provide, non-traditional avenues for folks to get, the care that they need, and be able to do that successfully from wherever they are. So.
Yeah, I mean, a success would be us not calling that non-traditional. Like, I mean, think about this. Like, that's traditional. Like, it's my community organization, it's how I operate, it's where I spend my time. I've got, the support of them. Like, that should be a channel for healthcare, and we should not be thinking about that as like, oh, it's in contrast to real healthcare, which is performed in the doctor's office. And I think the pandemic was so important to at least highlighting a lot of this. Like, we start thinking about community engagement totally differently now than we did 2 years ago. And if you're like, if there's a win in like actually thinking about the community as a partner, as where care can be delivered, just like we think about the home now and the way we think about the institution, maybe like the last 100 years, like it's such a departure from like the world of, well, care is only delivered in the doctor's office or the hospital. And it's like, pick your poison. And I think that shift in mindset is huge, right? So just what you're describing, like screening through the community, where is that happening? How do we make that more part of the experience of a patient? Well, that's going to raise rates in communities just by like finding patients and meeting them where they're at. I mean, that's such a huge opportunity for us. So I totally love that. And I think it's an area we give a lot of lip service to, but to actually go out there and be like, yeah, we're making our screening tools available. Here's how we're working with communities to do that. But how do we do that across the country, right? I mean, we could start in a couple places where we've got the relationships, but like, you're just curious, like, how do we activate like this across the country, find other folks to engage? Like, how do you get the championship, like championing this idea beyond Atlanta? Like, just love to hear your vision on how we build that out.
I feel like I'm dominating the conversation, but yeah, we're beyond Atlanta already. We're partnered with organizations right now in Detroit, Philadelphia, Houston, Washington, DC, Los Angeles, Oakland. So really, growing the screening program to be a national screening program. Hoping this year to add folks in Chicago and New York. Really thinking, about those major hubs. And I think something we're also really trying to lean into is we know that, Black people just don't live in cities, right? So how do we get into these rural communities so that, folks who actually, may live, 50, hundreds of miles away from a hospital who don't, we know that, here in Georgia specifically, rural hospitals have been closing at a pretty rapid rate. Yep. And so, we want to be able to, again, deliver community care in a way that shifts. I mean, I wouldn't even say shifts, that has gone back to, the core of community organizing, right? And the Panthers did this work, right? They went into communities, established programs, and built resources up that then were able to provide care for their community, decentralized from the hospital or the healthcare system.
I think that's why partnership engagement is so important to us. So, we're based in Atlanta currently. Half of our team is born and raised in the Atlanta area. So we have a sense of the local context here and the community assets and needs and strengths and capacities of the Atlanta community. But this is just our local context. And so we really want to partner with community organizations in other cities, other regions that have been embedded within their own communities and, live, work, and play in those spaces. So they have an understanding of their community strengths and needs more than we would.
Totally. And I mean, that's the beautiful thing about partnering is that, you want to be working with organizations that are linked in with their community. And I think this is exactly the point, right? You've got these collaborations across major cities. And then to your point, how do we get into the rural? How do we partner and find others that are, shaped similarly, believe similarly in terms of our beliefs and like are able to, address the needs of their community? And it's such an important part of thinking about that, the scale up of that, because I think what happens is that a lot of people, they pilot ideas with community centers locally, and then they lack the infrastructure to bring things out to the national level. But I think, Khadijah, what you said is, well, you need partners. You need partners who are local in every one of the, like major areas, and then as well in the rural areas to make sure that we're actually getting to engage that community in the right way. So I really like that framework. And I think there's a lot, we can learn from just how you guys are actually going out there and bringing this across the country and, raising the awareness and then working with communities to drive the type of change that you're describing. So very, very cool. I do think about this topic that, we spent a little bit of time on, which is this notion that, we have a lot to work on to change. And, at Komodo Health, we work, across the healthcare ecosystem with payers, providers, life sciences companies, and one of the things that we spend a lot of time doing is even just highlighting disparities. And first of all, I agree with you on race as a social construct. I think we have historically dominated this notion of what race and ethnicity is. And it's like ingrained into the way that the census works and a whole bunch of structures that I think perpetuate racism more than address it. So we are 100%, recognition. We have 100% recognition of that. At the same time, because this is the way the structure is built, we are able to do studies that use these imprecise terms to kind of describe populations in a way that, allow us to identify disparities. But this is not the be and end all of disparity. And we need to get deeper than that. We need to start thinking a lot more about, the environment of the patient and a lot more beyond race and ethnicity as defined by the government, right? So one of the things that I would love to just hear you guys riff on, because, we're working with these large enterprise institutions that have their own ways of doing things. They're just now starting to think, wow, could we use race and ethnicity to start understanding disparities in care? And think about this from a life sciences company. Who's getting my drug? Are they getting branded drug? Is this the difference between folks who are Black and white meaningful? And is that creating worse outcomes? I mean, they're starting to ask these questions, which I believe they should be asking for the last 50 years, but at least they're starting to ask these questions now. I would love your advice on how companies should approach questions like this, how they, you use data to make better decisions, but at the same time, not make the wrong kinds of assumptions. This is a really important time to be having the dialogue with industry, but I also see it wrought with a lot of the kind of typical, okay, we're going to make some assumptions and that's going to lead to something that won't actually drive change. What would be your advice to companies that really want to start making commitments, start really getting deeper in it? Help us help that, give you some thoughts.
Yeah, I think what's really important here, I encourage organizations to do like an equity audit. Right? How are the tools that you're building? How are the programs that you have really impacting health equity? Are they right? You're either doing maintenance, so things are staying the same. You are improving health outcomes, or you're exacerbating health outcomes, right? And so I think it really has to be a really foundational value of your organization that, hey, we want to actually impact change. And, we want to change our systems, internal and external, to lead to that change. And I think it's also important that, we build and design programs with disenfranchised people, folks at the table, right? We can't build solutions for people. We have to build solutions with people. So you have to look around your organization, like who is making decisions, who has seats at these tables. Can we bring the community in to have a collaboration on what we're building? And that takes time. That's really counterintuitive to the way that startups work, the way that business works. Like we want to produce things fast as possible, right? And
get it out there, get it done.
Yeah, we want to get it out there. And I think, that intentionality, may slow your process down, but ultimately make your product better. And so I think we really encourage institutions, and I would recommend that folks, leverage their community, leverage folks around you. And if everyone around you looks the same, you have to bring other people in.
Yeah. Oh, that's great. Khadijah, any other thoughts on this? It's such an important topic.
Yeah. I just want to make a plug for the importance of disaggregating data by race, ethnicity. And I think that's something that Komodo Health does such a great job with. But you don't know where the disparities even exist if you don't have that important data. And I think COVID is a perfect example of us not knowing there were the COVID was disproportionately impacting Black communities, Indigenous communities, until we had that, both the quantitative epi data, but also the qualitative stories from the field. And so just starting with the data you're collecting, and again, making sure it's disaggregated, making sure you're not erroneously conflating like race as a risk factor, but really pointing to racism, and again, getting at kind of that social construction of race piece is so important to like a first step, a starting step to understanding where those inequities exist.
Well, it's a beautiful sentiment. And I think it's so important that, we are taking the time to understand and then at the same time, use that data to allow ourselves to, really validate certain hypotheses and then use that to then shape policy. And, I love the attention that policymakers are taking to using data like this to start identifying these disparities at scale and just say, hey, this is not imagined. This is what the data says, and this is significant, and we all need to pay attention to it, and then have intentionality in how we actually go address it. So I just want to thank the two of you, Khadijah and Matthew, for really taking the time to chat, to share your perspectives. It's so valuable. These are the kinds of dialogues that I think drive change in people's hearts and minds on why this matters and why it matters to us. And I think sharing the passion that you have around your organization and we on data and the mission of reducing disease burden really can go a long way to activating companies to think deeper and better. And I want to thank you both for your partnership, the incredible advocacy work that you're doing. And then just as importantly, the research that you're doing with us is outstanding. And I just want to thank you for the time you've invested. So with that, we'll get out. I want to just shout out Black Health. Check them out at BLKHLTH.com. Follow them on social media. Thanks everyone for listening and for taking part today. Take care.